Hello, everyone, and welcome to today's webinar, The Evolving Landscape of Lung Cancer Treatment. I am Shelley Mulock of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com. I'd like to now welcome our speaker, Professor Michael Thomas. Professor Michael Thomas heads the Department of Thoracic Oncology at the Thoraxklinik, University of Heidelberg, and is a member of the Board of Directors of the National Center on Tumor Diseases in Heidelberg. Michael, you may now begin your presentation.
Hello, my name is Michael Thomas. I'm the head of the Department of Thoracic Oncology at the Thoraxklinik at University of Heidelberg. And today I would like to go with you on a journey on the evolving landscape of lung cancer treatment. Here are my disclosures, and my focus today will particularly on non-small cell lung cancer, and at the key date of diagnosis, around 60% of patients present with local regional disease and 40% of patients have metastatic disease. And if we would step back 20 years ago, we would have had this counseling situation in the metastatic disease scenario. Unfortunately, there is no cure. There is not even a race for a cure. And this due to the results here from the comparison of different chemotherapy regimens published in the New England Journal of Medicine. And you see independent which combination you would have chosen, 2-year survival rate is around 10%. So 9 out of 10% would not be still alive after 2 years in the metastatic scenario with this type of treatments. And this has changed substantially. As you see here, this is an epidemiologic analysis published 2020 in the New England Journal, and this is reflecting the lung cancer incidence and incidence-based mortality, gender-specific in men and in women. It's based on the US SEER registry, and the blue curve is representing the incidence in total, and you see, fortunately, the incidence is dropping down in men substantially and in women modestly, but the mortality rate is even dropping down steeper, at least since 2013, minus 6.3 for men and minus 5.1 for women. It's the steeper drop down than the incidence. And this shows there is something in the population that now is improving the outcome and is reducing mortality. And this has been indeed the introduction of targeted treatments 5 to 8 years prior to this key date of 2013. And here on the next slide, you'll see the molecular pie chart. It's very important to know the molecular subsets, particularly in adenocarcinoma. And as you see, around 50% of patients could be attributed to different molecular phenotypes which are prone to targeted treatments, and these patient populations will really benefit from this type of treatment with a differential effect in outcome, which I will elucidate in the next minutes while we walk further into those treatment conceptions. The first one and the most prominent one introduced into this molecular scenario has been the EGFR mutation. So molecular alterations of the EGF receptor. And here, this cartoon reflects the response rate on the one hand and progression-free survival on the other hand. And in first-line treatment, we see a response rate of around 75%, for instance, for osimertinib, a TKI which has been introduced into the treatment scenario around 4 or 5 years ago. And you see the progression-free survival time in the median is 18 to 19 months. And the blue spotted box is indicating median overall survival. It's 38.6 months for this compound. Though this is something which really offers benefit to the patients with these alterations. And at least it's important then, if patients elapse to control with this type of treatment, are there further underlying molecular mechanisms of escape that could be perhaps utilized for next treatment steps? And so it's very important to have a re-biopsy, or at least a reassessment of a change of the molecular pattern, which is at best done by tissue, or if it's not possible, by circulating tumor DNA. And on the left hand, you see again the molecular pie chart of molecular alterations after failure of first-line osimertinib treatment. And in the lighter gray, there it is a part of the pie chart indicating transformation. That means that those patients experience transformation into small cell lung cancer, and this only can be diagnosed on the tissue biopsy. And here in the molecular scenario, you see most prominent and predominant are MET amplifications, which is yellow colored. It's around 15% of the patient population. In particular, for this part of the population, treatment opportunities are out, at least in the context of clinical trials. We have seen last ESMO the results from the INSIGHT-2 trial, the phase 2 trial, which has explored osimertinib in combination with tebutinib, which is a c-MET inhibitor. And you see response rate is meeting 50% or even higher, so it's effective, this combination. And the enrichment strategy and detection strategy for those patients has been based tissue-based on FISH analysis, or liquid biopsy based on NGS analysis by the ARCA technology. And threshold has been a MET copy number gain of 2.3 in the liquid or over 5 in the tissue. And by this enrichment strategy, this combination is exerting those effects that I just showed. And further opportunities are around in those patients with MET alterations or with MET amplification, particularly after failure of first-line osimertinib. So a further opportunity, for instance, is a combination of amivantamab with lazertinib. Amivantamab is a bispecific antibody targeting c-MET and the EGF receptor. And here in combination with lazertinib, which is a third-line TKI tackling the EGF receptor as well. And this combination, as you see, exerts efficiency rates around 33%. And osimertinib and savolitinib is again a combination with MET TKI. It's another compound than tebutinib. If we stick to the c-MET domain, here you see that these opportunities are broadly set up. And so it's not only tebutinib which is in the field, it's savolitinib which is tested, or amivantamab with lazertinib. And if we walk further forward, what are other options if patients elapse towards TKI treatment options? Antibody drug conjugates walk into the field as well. And the both to mention here is patritumab deruxtecan, which is targeting HER3, and datopotamab deruxtecan, which is targeting TROP2. And you see those antibody drug conjugates exert similar response rates, 30 to 40%. Antibody drug conjugates by this conceptual slide are designed in that way that we have a toxic payload that is linked to the Fc fragment of the antibody, and the Fab fragment then is detecting the respective antigen. After antigen binding, the internalization via endocytosis is then there, and with that then the lysosome is then degrading intracellularly this antibody drug conjugate, and then a release of the toxic payload is taking place, and toxic payload might exert efficacy intracellular on the one hand by DNA intercalation, or on the other hand by microtubule disruption, and then drive forward apoptotic cell death. So this is the mode of action of those antibody drug conjugates, and which I would like to emphasize and stress. It's very important to even know very tiny populations which prevail in the 1 to 2% range if it comes to target treatment, because those target treatment options might offer a substantial benefit to patients. And one example, for instance, here are EGFR exon 20 insertions. So we still discuss on alterations in the EGF receptor, and here it's exon 20 insertion. It has a prevalence of around 1 to 2% with different insertion types even here. Those tumors characterized by these insertions carry a worse prognosis and are a good target for various new options. And here again, amivantamab, this bispecific antibody that I already mentioned, is in the field and received approval for second-line treatment. It's here in the colored box highlighted. Amivantamab tested in the Chrysalis trial package is showing a response rate of 40% and a median duration of response of 11 months. But you see, this scenario is getting more and more crowded. Further TKIs are introduced and tested, mobocertinib here to mention, or sunvozertinib, CLN 081. We have seen last ESCO for the first time in a phase 1 setting, showing a response rate of 40%, median duration of response of 10 months. And particular feature is that this compound is showing a very good brain efficiency if brain metastases are occur. And if you compare here by this reflection on early trials, mobocertinib is exerting the best median duration of response with around 18 months and an overall response rate of 28%. So this is just to mention that there is plenty of opportunities for a tiny patient population. And the molecular landscape has been nicely assembled here in this pie chart by Daniel Tan. He published this oversight paper in JCO last year. And the outer part of the pie chart is reflecting the Asian population, and the inner part of the pie chart, the Western population. And you see in the Asian population, it's less than 1/3 of patients that have a molecular undefined type of disease. For the Western part of the population, it's around 40%. So here are differences, and which I would like to stress again are the tiny patient populations. EGFR exon 20 insertion I did already mention, and other representative are HER2 exon 20 insertions, which prevail around 1 to 2% in total. And here we have an ADC, an antibody drug conjugate, which has been introduced into the treatment scenario, trastuzumab deruxtecan, tested in the DESTINY trial package. And you see in advanced treatment lines here an overall response rate of more than 50%, median duration of response 9 months. And here in the slide, different doses are depicted. And for 6.4 milligram per kilogram body weight, we have to see and we have to notice that the rate of interstitial lung disease or pneumonitis is quite relevant. Here in this trial, it has been 14%. In the lower dose, it's only around 6%. And so it's important to know that and step to the lower dose if you start this ADC, because pneumonitis is really important. It's really mattering to patients, and you could at least diminish the risk by stepping down in the dose. And here in this trial, it could be shown that it shows equivalent efficacy in terms of response rate, the lower dose. So it's always important to balance against the side effects and see what is the utility and efficacy of those compounds. I now step back to the pie chart that I already showed, and you see one further relevant domain are KRAS-altered patients. In total, these comprise 25% of adenocarcinoma patients, and around 50% of them have KRAS G12C alteration, here in the pie chart reflected as 14% of the total population. And here you see, here is again the taxonomy, KRAS in total 25%, KRAS G12C 12 to 14%. And here on the right hand, there is a list of different GDPase inhibitors that block the KRAS protein in the inactive state. And you see this is very crowded. It's reflecting here more than 12 of those GDPase inhibitors. So it could be shown that their efficacy might be exerted by blocking KRAS in the GDPase state. And the field is getting crowded very quickly. The first efficacy readouts we have seen on sotorasib and adagrasib, here in comparison in the discussion from last ESCO, and we see in the phase 2 settings that response rates are around 40%, with a median duration of response of 8.5 and 11.1 respectively, median progression-free survival around 6 months, median overall survival around 12 months. So no major differences between those GDPase inhibitors. And sotorasib then made it forward into the phase 3 trial setting, and the results of the phase 3 trial in comparison here, sotorasib to docetaxel in the second line setting, have been presented at last ESMO. And you see here in phase 3, response rate is 28% for sotorasib compared to 13% for docetaxel. And the 1 year progression-free survival rate is 24% compared to 10%. So there is an advantage, but it's not so tremendous. It's there, and sotorasib received approval for treatment. So it's a further accomplishment here in those treatment lines, a further offer to patients that could help to control the disease for a certain time period. In terms of overall survival, with a crossover rate of around 1/3 of patients with docetaxel crossing over to sotorasib, no difference in overall survival could be shown. So with these results, it seems to be important to think about, okay, how the effect could be increased, perhaps by combination strategies with other TKI options that interfere potentially with the RAS pathway, or with other options that increase immunogenicity with IO combinations. This is depicted here in this graph. And the graph as well depicts that with GDPase inhibition of KRAS G12C, we see a response rate of 30 to 40%. And in those patients with these alterations, we even see, if you look on cohort explorations, that immunotherapy might work in a substantial proportion, which is completely different in the typical targeted populations prone to targeted treatments with the classic EGFR alterations, L858R in exon 21 or exon 90 deletion, or ALK gene fusions, ROS gene fusions, RET gene fusions. Here we see response rates tackling 80%, and those defined populations are not prone to immunotherapy. Immunotherapy is not working efficiently here, though these are differences, and which what I would like to stress, it's important to think about how to increase the treatment efficiency in the KRAS population by the options that are outlined here. So to summarize here, if we put this into an overnight table, we have to state that by the various options of targeted treatments according to the respective molecular alterations, we have the response rates as outlined here, and progression-free survival times as depicted here in the table as well, and overall survival and median overall survival as depicted here in the table. You can take away that for the classic EGFR alterations, median survival might even meet 38, 39 in the median by osimertinib, which I already have shown. So this is, let's say, in that way, the best population with the best benefit in terms of TKI treatment. Now I would like to jump over to gene fusions, and here to name 4 potential fusion genes: ALK, RET, NTRK1, and ROS1. And if you look with those gene fusions again on the table, you see, for instance, for ALK, you could achieve a 5-year survival rate of 60%. So this is really a tremendous step forward for those patients. And in the patients with RET fusions, 3-year survival rates of 57% are already reported, and with further follow-up of those trials, even might meet a 5-year rate of 50% as well here. So these are really substantial steps forward in the gene fusion domain, and it's very important to detect those gene fusions. And here to say that besides DNA NGS for the mutations, RNA NGS for the gene fusions is very important and a very important tool when it comes to diagnostics. And even with RNA NGS, you can confer further informations to the treatment of patients. For instance, the fusion partner can be described by this methodology. And here I would like to show you on this cartoon the biological background in the ALK gene fusion scenario. And here are some of our own data are integrated as well, which we achieved and provided by cohort exploration in our own patient cohorts that we diagnosed with this type of disease, and which we treated either with chemo or TKI options. And you see again the molecular pie chart indicating ALK is comprising 3 to 5% of the total population in adenocarcinoma. The gene fusion is defined by an inversion of the short arm of chromosome 2 with a defined cut point in the ALK domain, various cut points in the EML4 domain. And according to the cut point in EML4, then you have as a readout different variants in the protein. And the most prevalent ones are the variant V1, V2, and V3. And you see if V3 is given, those patients upfront show a higher metastatic burden and substantially shorter time intervals of progression-free survival with TKI treatment. So they step very quickly forward from progression to progression and then succumb earlier than those ones with V1 or V2 due to their disease. And this we detected and this we explored by the iron torrent AmpliSeq technology and could show that this is given in this population. In addition, we could show that the occurrence of a p53 co-mutation is conferring to even worse outcome, either as an upfront alteration, there the prevalence is 20%, or if it occurs over time. And here an additional incidence of 20% has to be stated. And this we could check by ctDNA tracking over time, the occurrence of p53 co-mutations. And we could even detect by ctDNA tracking early relapse of disease by looking on the variant allele frequency. And this indicated relapse with a lead time of 4 months prior to relapse in the imagings. And in addition, by doing in-depth analysis of the ctDNA, we even could check back, is there a resistance mutation in the ALK gene given, which could then offer a next type of treatment potentially, as it's an on-target resistance that is occurring here. So a lot of information by doing appropriate genetic analysis upfront and even over time. And with that, I would like to state here, particularly with the genomic landscape, which is now a background of disease in non-small cell lung cancer, definitely to say one size does not fit for all, and you really should know with which part of the population you are dealing with to employ appropriate treatment and to move forward into the target treatment space. A major step forward, a really transition of the treatment field, has been given by employing tumor microenvironment to eradicate cancer and to really go forward to cancer cure. And here a landmark trial has been the Keynote 024 trial, which employed a PD-1 checkpoint inhibition, here in this case pembrolizumab, against metastatic non-small cell lung cancer. And this opportunity has been compared to chemotherapy, combination chemotherapy, which has been the standard of care in these times. And the updated trial showed in 2021 that a 5-year survival rate with checkpoint inhibition in the PD-L1 high expressing a PD-L1 of more than 50%. The 5-year survival rate here has been 30% compared to 16% with combination chemotherapy, though this has been a really step forward and a proof of concept in this treatment field. And here again, the molecular landscape might play a role. At least it has been shown in this retrospective analysis published 2021 by Ricucci and co-workers, just in this populations that I just mentioned, with the PD-L1 expression of 50% or higher, exposed to this type of treatment with PD-1 inhibition, in this case pembrolizumab. It could be shown that those patients that in their tumor carried a KRAS mutation and in addition an STK11 or KEOP mutation showed worse outcome, as represented here by the red curves in the upper part of the Kaplan-Meier plot compared to the blue curves. Those are the one with KRAS mutation, but without additional STK11 or KEOP. And this is completely different if it's KRAS wild type. Here, those additional mutations don't matter. Outcome is similar. So here it could be shown that these molecular features matter to show how the prognosis is looking like and how the outcome according to this IO monotherapy is different. And this might give energy to the hypothesis and raise the hypothesis that those patients, for instance, with KRAS mutation and STK11 mutations, need a different type of treatment upfront than IO monotherapy or chemotherapy with IO monotherapy. I will come to that back later with my presentation. At least if you look on the pie chart, not on the pie chart, on the overview graph, showing us the different treatment options in first-line metastatic non-small cell lung cancer, you see it's plenty of options. And the attrition according to the respective treatments is driven by the PD-L1 expression and the histology. And we see, independent from histology, in PD-L1 high expressors over 50%, we have different trial options: KEYNOTE-24, IMpower110, IMpower01, which are reflecting different compounds from the PD-1 or PD-L1 treatment options, and those are pembrolizumab, atezolizumab, and cemiplimab, to name those here. And then, moreover, according to histology, there is KEYNOTE-189 and KEYNOTE-407, or IMpower150, IMpower130. These are trials that combine IO monotherapy with chemotherapy. And these are further options that are introduced into the treatment landscape here in addition. And just now, IMpower03 received approval in patients with a PD-L1 expression over 1%, independent from histology. And this is cemiplimab in combination with any type of chemotherapy. In combination with chemotherapy, and here again then combined IO approaches, these trials are CheckMate 9LA and Poseidon. And in CheckMate 9LA, it's a combination of anti-PD-1 with anti-CTLA-4, and Poseidon is anti-PD-L1 with anti-CTLA-4. So it's PD-1 and PD-L1. This is the difference between those two trials. And as the Poseidon trial just now received approval, I will show you that in the next minutes. But first, I would like to introduce you a little bit on the efficacy rates, long-term efficacy rates of chemotherapy combined with IO monotherapy. And here, chemotherapy with anti-PD-1 treatment. And the first compound introduced in the field here has been, again, pembrolizumab. And we see in these combination strategies, the 5-year survival rates are meeting a proportion of 20% in the total population. It's 19.4 and 18.4 according to the respective histologies. And I already introduced you into the results from KEYNOTE-024, where we had a 5-year survival rate of 30% in the high-expressing population. And this again is met in KEYNOTE-189 in combination with chemotherapy, again 30%. And in the KEYNOTE-407, it's not so much favorable. It's in the midst of the 20% range for squamous cell carcinoma. So, but in comparison to chemotherapy, these are really steps forward again here. And these are further opportunities, combination of chemotherapy with IO monotherapy for those patients. And if we sum this up in an oversight table, we can state that by these options, 5-year survival rates are 30% in the high expressors and around 20% in the total population. If we look on stage 3 disease, which is local regional advanced, mostly not prone to surgery, then those patients receive chemotherapy in combination with radiotherapy to control their disease. And some years ago, in addition, anti-PD-L1 treatment has been introduced as an adjuvant option, and in this case, durvalumab. And in the trial which started that and conducted that, we saw a 5-year survival rate of the total population of 43%, and in the patient population with a PD-L1 expression of 1% or higher of 50%, which is here the Pacific trial. And you see the both Kaplan-Meier plots indicating that, and this is putting evidence in this field as well, that patients with local regional advanced disease and radiochemotherapy are benefiting from adjuvant anti-PD-L1 treatment, and in Europe, the approval is given for patients with a PD-L1 expression of 1% or higher. And with this, now I step back to the Checkmate 9LA and Poseidon. These are the trials that I already introduced to you, with a combination of anti-PD-1 or anti-PD-L1 with anti-CTLA-4 with combination chemotherapy. And very recently, Poseidon received approval just in the last weeks. And here, this trial compared chemotherapy versus chemotherapy plus anti-PD-L1 durvalumab, or in addition, in conjunction with durvalumab, anti-CTLA-4, in this case here, tremelimumab. And you see, for the quadruple combination, we have the best hazard ratio of 0.75 with a 4-year survival rate of 20% for those patients. And if we look at the forest plot, we see a differential efficacy according to histology. And here it's indicated that the utmost benefiters are those with a non-squamous histology with a hazard ratio substantially lower than 0.75. And here on the next slide, this is depicted. If you look on the non-squamous population, we have this favorable hazard ratio with a 4-year survival rate of 25%. So some percent even better than in the total population, where it's only 20. And for the chemotherapy-only population, it's around 10%. So this is a very huge difference here. And it seems to be the case that particularly for this histology, this combination has the best benefit. And here now in this part of non-squamous, further results on STK11 alteration and KIRP alteration and KRAS alteration have been made available last ESMO meeting. These Kaplan-Meier plots, which are absolutely exploratory, have been presented. And the information is that even due to STK11 mutation or KIRP mutation, patients with this quadruple type of treatment seem to benefit. This is exploratory, it's retrospective, it's a signal that shows that perhaps those patients might be forwarded to this type of combination treatment at best, but this is, in my perception, it's an hypothesis which has to be further explored and validated, and is showing how important it is, and it will become in the future to have this molecular information even in the treatment scenario with immunotherapy. And here I would like to sum up that substantial progress has been made, but advancements are imperative, particularly to customize ICI immune checkpoint inhibition to the respective patient populations. And this is even very important if we look, on the next treatment options that we have available for those patients. If they fail to first line, then it's becoming very sparse, the opportunities. And you see here different options that have been tested, not after failure of direct chemo IO, but failure after chemotherapy. And here we have, in the second line scenario, no substantial response rates to expect, almost less than 10%, and progression-free survival in the median is almost less than 3 months. So very limited, very sparse options. And this is a reason why now, after failure of chemo IO, different opportunities are tested in terms of antibody drug conjugates as listed here, new immune checkpoint targets, or combination of checkpoint inhibition with receptor tyrosine kinase inhibition, or checkpoint inhibition with anti-TIGIT checkpoint inhibition. So different options are currently explored, and it's very important to deepen the understanding. And here again, a nice approach from Ricuti and co-workers that has been presented last ESCO meeting. What did they do? They followed up their patient cohorts with sequential biomaterial acquisition, here with sequential biopsy taking. And in this patient population was around 60 patients which have been exposed to different types of immunotherapy. They could show that the genetic landscape, if you explore the genetic landscape in appropriate depths, could confer additional information on the potential mode of resistance. So that they described in around 10% of patients the occurrence of an STK11 mutation, which is contributing to a microenvironment which might then bring checkpoint inhibition into an inefficiency. And the same to say here for loss of function mutations in the beta-2 microglobulin, and these could be detected in around 8% of patients. So if you do this type of exploration, you might achieve further information which might help you to move forward on next steps of treatment to scavenger those patients and induce again a remission if possible. And with that now, I would like to move forward into the perioperative treatment setting. And here it's important to state that even in small tumors, let's say 2 centimeter tumor, 1 or 2 peribronchial lymph nodes involved, this is stage 2B disease. The overall survival is not overriding 50% substantially, so it's very important to have improvements here. Attempts of improvements have been made with chemotherapy 15 years ago, introduced, and we see here that the survival rates are improving, but it's not substantial. It's 4 to 5%, so it's a very little step forward. And in the very recent past, it has been shown that it might be important to know the genetic landscape here as well. At least it could be shown for activating EGFR mutations. That's the additional treatment with osimertinib is putting substantial benefit on the improvement of the disease-free survival with hazard ratios of 0.4, of 0.3, and 0.2 in the disease-free survival. And we note that the 4-year disease-free survival is ranging from 80 to 65% in the different subgroups compared to 59 to 14%. So substantial steps forward. But in addition, to mention here, or not but, perhaps for further information to mention here that ctDNA tracking and ctDNA drop down might matter here in this part of the population as well to guide treatment. Here, this nice exploration from South Korea presented by Ahn and co-workers last ESMO. Here it could be shown that in patients treated with surgery with an EGFR alteration, and they had a huge population, 278 patients, predominantly patients with stage 1 disease. It could be shown if patients had no ctDNA detectable upfront to surgery or had a ctDNA drop down after surgery, had a favorable 3-year disease-free rate of 80% compared to only 50% if patients had a ctDNA detection prior to surgery and no drop down. So the no drop downers seem to be those ones that carry the worst prognosis, and perhaps those are the ones that particularly benefit from treatment with TKIs like osimertinib. We will see an update on the AD-AURA trial, this ESCO meeting, and perhaps further information on the ctDNA dynamics are implemented here as well. And now for the last minutes, I would like to show you the impact of checkpoint inhibition, utilization of microenvironment in the perioperative treatment scenario. The first trial who now moved in a type of checkpoint inhibition in the perioperative setting has been IMpower 10. And this trial tested the impact of atezolizumab after complete tumor resection and adjuvant chemotherapy. And as you see in the patient population with PD-L1 expression, there is an advantage with a hazard ratio of 0.66, but the utmost advantage is in the patient population with a PD-L1 expression of 50% or higher. Here, the hazard ratio is 0.43. And in Europe, atezolizumab received approval for this patient population, and currently patients are then tested in terms of genomic alterations, in terms of PD-L1 expression, and those patients without targetable genomic alterations, particularly activating EGFR mutations, but a PD-L1 expression over 50%, would benefit from adjuvant atezolizumab treatment. Turning this a little bit around, another perspective could be to employ immunotherapy alone or in combination with chemotherapy prior to surgery. So induction, neoadjuvant. From a conceptual frame, the advantage could be that you have a broader T-cell response, a more diverse response of the T-cells to different antigens, more intense response with a higher clonality, and potentially a more sustained response with a longer T-cell propagation, which of course is important if the tumor is taken out. You would like to have a long-standing propagation and long-standing control of micrometastasis. And here perhaps an early readout on the efficacy could be the pathologic response in the resection specimen. And this is reflected here. This is just a taxonomy of the different response rate. PCR means pathologic complete response. MPR means major pathologic response with a viable tumor proportion of less than 10%. And you see here the numbers with CTX, which is chemotherapy with immunotherapy only, and with chemotherapy in combination with immunotherapy. And you see the best PCR rates and MPR rates are achieved with the combination of chemo with IO, with around 30 and 60% respectively. And in how far this might mirror the treatment efficacy could be delineated from this exploratory analysis from such an induction trial, which is Checkmate 816. 3 cycles of nivolumab in combination with chemotherapy have been here employed in the exploratory treatment arm. And you see there are differences in the event-free survival by PD-L1 expression. At best, again, patients with PD-L1 expression over 50% benefit here with a hazard ratio of 0.24. But in terms of outcome with reflection on the pathologic complete response rate, I would like to drive your attention to the lower part here, to the Kaplan-Meier plot. First to mention that the PCR rate is increased tenfold if you employ nivolumab compared to chemotherapy only. It's 24% compared to 2.2. And those patients with a PCR reflected here in the green curve with nivo chemo benefit better than patients without a PCR. And the hazard ratio for those patients with nivo chemo is 0.13. So it's a real benefit if this is given. And in how far preoperative and postoperative ctDNA might matter here. In the upper part, it's reflected that around 50% of patients with nivo chemo showed a ctDNA drop down. This is a green bar. And almost 50% of those patients, again, showed a pathologic complete response. So an additional proxy for PCR might be the ctDNA drop down. And ctDNA drop-down is even indicating superior or worse outcome, as shown in the lower graphs. This is an exploration by Cancer Research UK, published in Annals of Oncology last year. And they just compared pre- and post-operative ctDNA. And the first graph shows if no pre-operative ctDNA is shown, patients have a better outcome. And the second graph is showing if patients have post-operative still sustainable ctDNA detection, they have a far worse outcome with a difference in the hazard ratio of around 10. And this shows that perhaps the exploration of ctDNA perioperatively might help us to adopt treatment intensity. And these are strategical considerations published by Sanz Garcia and co-workers to adopt treatment according to the ctDNA dynamics. So checking back on that might help to guide treatment in the future. And the perioperative and particularly the preoperative treatment setting is giving us various opportunities. It seems to be, from a conceptual background, help to intensify the immune response by the markers that I just mentioned, biomarkers over time like ctDNA or PCR and MPR as a single shot readout. Post-operative treatment potentially could be stratified according to those patient populations. And it's a window of opportunity because here different approaches could be explored and could be correlated with biomarkers either in the pinpoint setting or over time. If it comes to ctDNA, to explore different opportunities, for instance, of checkpoint inhibitors, and then adopt according to the prerequisites represented by exploration of the microenvironment or the genetic landscape of the tumor itself, treatment strategies at best to those patients. So in my perception, the induction treatment option in the perioperative setting is at least a window of opportunity to explore treatment options, and then perhaps could be further moved forward into the treatment setting of advanced disease or metastatic disease. And this is to come in the very next future to design treatments in that way. And with that, thank you very much to be in this webinar on the quickly evolving treatment landscape of non-small cell lung cancer.
Thank you, Michael, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. We'll answer as many of your questions as we have time for. Let's get started. Our first question for you today, Michael, is in lung cancer research, are there any significant advantages in using genetic analysis approach over traditional techniques such as histology?
Yeah, definitely. This is the case. When you followed the presentation that I provided, you recognized by this epidemiologic analysis that has been published in the New England Journal about 2 years ago, it could be shown that there is a reduction in lung cancer mortality in men and in women, which is higher, this reduction, than the incidence of lung cancer. And this is has been observed in conjunction with the introduction of targeted treatments, tyrosine kinase inhibitors. First one in this domain has been the inhibition of the EGF receptor, and the dominant activating mutations that have been described here are exon 19 deletions and L858R mutations in exon 21. And these alterations and further ones, like for instance gene fusions and other mutations, are detected by genetic analysis. So this is not possible by histology itself or additional IHC stainings, though you need this technology and these assessments. And if you then employ the appropriate treatments to the relevant patient subgroups, patients are really going to benefit. This has been shown in the population-based analysis. And if you look cohort-based, if you know, for instance, this patient has an ALK gene fusion and you introduce the appropriate treatments, you could expect a 5-year survival rate of over 60%, which has been impossible and not been considerable about 15 years ago. So this is a real strong step forward, and diagnostic is key here in this domain to have appropriate patient attrition.
Wow, thank you for that. That's so helpful. The next question that we have, what are the benefits of qPCR and NGS complementary with each other in translational cancer research?
Yeah, could be. This depends at least on the strategy that you are pursuing and in which clinical frame and in which type of exploration you are introducing these technologies. So NGS could provide you with a complete overview on molecular alterations that might be given. So the NGS strategy is really important to have it if it comes to upfront exploration of tissue and the molecular landscape the patient might carry, and if you or the tumor might carry, and if you know a defined alteration is there, then it might be important to track over time what is happening. Is it reappearing? Is it extinguished by the treatment that you're conducting? And this could be tracked by circulating tumor DNA. And if you have this strategy, here qPCR could be an appropriate technology to track over time defined alterations in terms of getting insights on the efficacy of treatment, inefficiency of treatment, relapse. And this then would make sense if you can link consequences to the insights that you're gaining with this type of follow-up surveillance.
Wow, that seems very useful. Thank you so much for that. The next question that we have is, what are your thoughts on using multi-omics approach to identify new targets and biomarkers, especially when dealing with more precision-oriented treatments?
Multi-omics approaches might gain insights that are relevant. So, for instance, just to take a simple example, it could be shown by cohort exploration strategies with in-depth molecular phenotyping of those patient cohorts that in the conjunction with immunotherapy by its own or in combination with chemotherapy, defined populations might have not such a beneficial outcome. For instance, it could be shown that patients that carry a KRAS mutation and in addition an STK11 or KIAP mutation don't benefit in an appropriate way from immunomonotherapy, even if they carry a high PD-L1 expression. And this is just an observation by retrospective cohort exploration. If you now think this forward and you would provide a broad-scaled multi-omics approach or even multi-level characterization, in addition to the genetic alterations, perhaps looking on cellular composition of the microenvironment, if you would go for decomposition strategies, for instance, with nanostring analysis to get some insights and information here. This could be something which really could help you to better guide treatment options like immunotherapy. And here in the next future combination strategies come around the corner. For instance, targets that are tackling LAG-3 are under exploration, just to give this example. And for this sole target, different antibodies are currently tested. So it's getting very quickly, very crowded, and here appropriate guidance would be key, and here multi-omics could be something which is really going to matter in the future. And again, here it's important to link the strategies to appropriate trial exploration efforts to gain relevant insights to better customize treatment.
Wonderful. Thank you. We have time for one more question today. Our last question this morning is, how is the introduction of different ways in treatment of lung cancer, as mentioned in the webinar, relevant on the basis of population extent?
Yeah, it's very important. As you perceived, immunotherapy has been introduced in the field starting in 2015, 2016, first in second-line metastatic disease, then in first-line metastatic disease in defined patient populations. Now it's spread overall in the metastatic non-small cell lung cancer field in local regional advanced disease, and it's now even moving further forward into perioperative treatment options in the perioperative treatment field. And so here in the future, it will be very important to better define patient subgroups that benefit from defined strategies. I just mentioned combination efforts that are currently undertaken. So it's very important for the next 10 years to better understand which patient subgroups might benefit from which types of combination, either in the field of immunotherapy or in the field of molecular alterations. A further example that we can cut out of my presentation is, for instance, KRAS mutation G12C. There is an effective treatment or TKI and GDPase inhibitor. It's not a TKI inhibitor, a GDPase inhibitor out that shows some efficacy, response rate about 20 to 30%, progression-free survival 6 to 7 months. So it's efficient, but it's not ultimately efficient. And here, then it's important to better understand which combination strategies might work here in the future. So it's very important to better understand which patient subgroup in which treatment line is benefiting from which strategy.
Sure, that makes sense. Thank you for that. Thank you, Michael, for your informative presentation. So we just want to ask you if you have any final comments for the audience today.
Well, thanks for participating and being here in the webinar. As you have seen, thoracic oncology here on the example of non-small cell lung cancer is a very exciting field. Never ever this would have been expected 15 years ago. It's very exciting now, and there's a bright future. So thanks for being with us here. Thank you.
Excellent. Yes, thank you again, Michael, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Until next time, goodbye.